Hi everyone, welcome to today's live session. My name is Zoe Clark. I'm Senior Self-Management Programme Officer at NASS, and today I'm very delighted to be joined by Dr. Helena Marzo-Ortega, who is a consultant rheumatologist and associate professor. Hi Helena, thank you so much for joining us.
Hi Zoe, thank you very much for having me. It's a pleasure to be here sharing these minutes with all of you.
I know you're a busy lady, so I really appreciate it.
Yes, coming off clinic as we speak.
Perfect timing. So for everyone watching, today Helena is going to be talking about women and axial SpA, and we will soon also have an expert joining us to talk about men and axial SpA as well. So we'll have a balanced view on everything. If you haven't seen one of our Facebook Lives before, then just to make you aware, the video will stay on our page afterwards. You can watch the whole thing back anytime. And we'll also pop it on our YouTube page and also our webpage, My AS, My Life as well. And would you like to introduce yourself to begin with, Helena?
I do. Sorry about the movement. I've just realized I didn't have my telephone with me, and I need to be to have it on just in case I get caught. Okay, so well, you've already said, so my name is Helena Marzo-Ortega, for those of you I haven't met, which I guess it will be the majority of you. And I am a consultant rheumatologist based in Leeds, where I'm also lucky enough to lead the specialist spondyloarthritis service. I feel very proud about this because we've come a long way over the last 20 years building this up. What is frustrating is sometimes you cannot really tell from your side. Yeah, when patients come to clinic, they look at it and they think, well, it's the same old walls. You've literally just only given it a bit of fresh paint, but there is a lot of work going underneath the scenes. Sometimes it is frustrating for us that it cannot show, but we are definitely trying our best to improve the lives of people suffering with all musculoskeletal conditions. But in my particular case and in my service, I work with my team very hard to improve the lives of people with axial spondyloarthritis as well as with psoriatic arthritis. So it is a pleasure to be here.
Absolutely, and thank you for all the hard work you and your team do. And we've actually already had a comment from Gillian saying thank you for all that you do for us with AS. You're a star, so lovely comment already.
No, I'm not a star, but we keep busy. I think one of the most important things in this area is that we are such a small, if you like, a specialty. I mean, for all of you, of course, this is what matters. You have to live with this condition, and for you, this condition is paramount at the forefront of your life. But in the big scheme of things, you probably, can find difficult to understand that the majority of people in this country have never heard of Axial SpA. They cannot you cannot understand it or let alone pronounce it. So it is a lot of work, that needs to be done in this area. I don't know whether you know, but axial SpA at the moment is probably as prevalent as multiple sclerosis in the UK. Yet people have heard much more about MS than what they've heard about axial SpA. So yes, there is a lot of work there to be done. We work in the dark. This condition is very much an invisible condition, causing a lot of problems, admittedly. Okay, so here we are. Ignore the peer voice, that is not referring to this webinar, but I just wanted to talk to you a little bit about sex and gender differences in axial spondyloarthritis. Okay, so the first thing I probably should say is that sex and gender are not exactly the same construct. So we tend to use the term interchangeably. And we have not really been talking about gender in the context of MSK diseases for very long. And I think the reason why we're using the term gender is basically because people didn't want to use the term sex. But now we are we're starting to understand that actually gender may not be that far-fetched. But just to clarify that when we talk about sex, we're actually talking about biological traits that makes us different, women from men. And sex tends to be, very much either female or male. But when we talk about gender, we're actually referring to the cultural meaning that society or the individual may attach to being masculine and feminine, or perhaps to other genders such as non-binary and so on. So this understanding of what sex or gender characteristics are will influence personal identity. And of course, this is again different from something like sexuality. Will refer to, sexual attractions, practices, and identity. So really, when we're talking about sex, we're actually talking about the things that differentiate us, which are biologically determined. So basically, what we are born with. Whereas when we talk about gender, we're actually referring to how we understand our sexual differences. Now, I guess a lot of you out there in the audience would have initially received the diagnosis of ankylosing spondylitis. And then a few years down the line, the doctor may have come to you and said, well, actually, what you have is axial spondyloarthritis. And I just want to clarify that this is, of course, the same term referring to the same condition. What has happened in the last 20 years is that we've realized that not everybody who suffered from axial spondyloarthritis could be diagnosed as having ankylosing spondylitis. When we talk about ankylosing spondylitis, it means that we can see things on the x-rays that makes us believe that people have had back pain for a very long time, they've had inflammation, and that has affected their radiographic appearances of their sacroiliac joints and the spine. But what we've come to understand is that not 100% of people with axial SpA will actually develop these abnormalities that allow us to diagnose them. And hence, we couldn't just give them the name ankylosing spondylitis. And this is why we thought, okay, how about we just talk about axial spondyloarthritis? And I'm sure you're all thinking, well, couldn't you have chosen a better name? And up to these days, I believe that we really need to have a better name. But what we're using is very old style definitions. So when you think about a spondylitis comes from the Greek spondylo and refers to back. The itis on it means that there is been inflammation in the back. And axial just refers not only to the back, but the joints that actually hold us straight on the axial skeleton. So we could include, for instance, the hips, and other people sometimes include the shoulders and the upper neck joints. So basically what we're referring is to an arthritis which affects primarily the back, although of course we know that it can also affect all the joints. Now, traditionally, we thought that this was a male disease. And why? Because the majority of people that got the diagnosis of ankylosing spondylitis was male. And why is that? Well, what it is clear now is that males seem to suffer from a more severe type of this condition. In other words, they start with the symptoms earlier and they progress faster. So it is more likely that we find abnormal x-rays and abnormal scans on a male than a female patient when they come to our clinic. And we don't completely understand why this is. But what we know is that in both cases, in both sexes, disease tends to start in the early ages, either in the late teens or in the early 20s. And what we find, as I've just said, is that the majority of men will actually show their disease on the x-rays, which is why sometimes we call them radiographic axial spondyloarthritis or ankylosing spondylitis, whereas women are less likely to show these changes on x-rays, and they tend to be more on the category that do not show changes either on the x-rays or the scans, and we have to diagnose them based on clinical findings. So one thing that we are fighting is how come we are so bad at diagnosing this condition? So I'm sure a lot of you will feel identified with this. It takes sometimes more than 10 years for somebody with axial SpA to be given a diagnosis. Now, for the last 20 years or so, we've been working in what we call early arthritis clinics. And what it means is that we ask general practitioners to refer patients to us as soon as inflammatory symptoms start. These inflammatory symptoms may be swollen joints, or it may be painful joints, or it may be painful backs. Okay? So from the moment the patient is referred to us and we're able to make the diagnosis, or from the moment, better than this, in this slide I'm showing you, from the moment patients develop symptoms and they get a diagnosis, we take on average 2 years to diagnose rheumatoid arthritis, as you see on the left-hand side. We take barely 4 years, a little bit less, to diagnose psoriatic arthritis, yet we take nearly 8 years to diagnose axial spondyloarthritis. And some of you who actually may have had problems with peripheral joints, with swollen wrists or feet or ankles, will be thinking, I do understand that, because it is easier for people to disclose a swollen joint than to disclose a painful back. People in general tend to cope with back pain for far longer than they would cope with a swollen wrist, for instance. Because if you have swollen wrist, you take yourself to the doctor readily. First of all, because it hurts, because you don't like to see the swelling, but also because it's impacting on your ability to do things. You may not be able to hold a kettle, you may not be able to cook, you may not be able to work at the computer. And it's this sort of presentation that would make you, and this impact of disease that would make you go to your GP faster. But in general, believe it or not, women tend to develop more peripheral arthritis than men. So one would think, well, okay, if women have got more axial spondyloarthritis with swollen joints, surely they should be getting diagnosed faster. I'm not pretending that you're going to understand or even try to read this slide, but this is just to remind me to tell you that this is not the case at all. So women tend to spend longer time hanging around in the system, and this is the healthcare system, that men do. So for instance, women will be more readily referred to a physiotherapist, or perhaps to the A&E department, or to ophthalmology because they've developed uveitis, or to the sexual health clinic because they're very young and they've got symptoms of a possible transmitted illness with a swollen joint. They will just be hanging around for much longer than men. So men tend to be referred to rheumatology faster than women. And again, we don't know why that is. But clearly, as we've just said, women and men present differently. So when we look at women, they're going to report more disease activity. They're going to report more widespread pain. They will have also more fatigue and in general, more functional impairment. And despite this, it's taking us on average a year longer to diagnose women than to diagnose men. So you remember the slide that's showing you before that there was nearly 8 years to 10 years of delay. This is data from the UK from 2015. So it's not from a million years ago. It's still quite new data. So we're taking nearly 9 years, 8.5, between 8.5 and 10 to diagnose men, and a year longer to diagnose women. By the time that women come to us, they already have a considerable burden of problems. So the disease has already made an impact. This slide is just showing us data that comes from the Corona Registry. This is an American registry, which is looking not only at axial spondyloarthritis patients, but also at psoriatic arthritis patients. We've got in red females and in blue males. And what you can see here is that whether we're looking at pain or fatigue or work impairment, meaning work productivity loss, we can see that the impact of disease is higher in females than in men. And when we actually talk about work productivity loss, what we mean is that women are more likely to give up work earlier than men. So earlier, I mean in their 30s or in their 40s. They're more likely to have impairment at the workplace. In other words, that if they go to work, they feel that they're not performing the same. And they're more likely to be work unstable, basically having issues at work and problems to keep up with the pace at the workplace by the time they're first seen in the rheumatology clinic. So this is actually quite a lot. So what we're saying is it takes a long time to diagnose women. The disease may not be as easy to see in women than in men, and that by the time they come to see us, women tend to have an awful burden from the disease. And if we look at drugs, for instance, and drug treatments, what we also know is that when we need to escalate therapy, when we need to go from anti-inflammatories to biologic drugs, for instance, we know that females tend to respond not as well as males. And this is very frustrating for us. What happens is females tend to be shorter time on each drug. They don't tend to get the same profound response. So they will not be having the 80% improvement that we sometimes expect, perhaps, or even the 50% improvement. And also they are more likely to change from one drug to the other. And we're not completely clear why this is. And the reason why we're not clear is because we have not really done the studies to look at this, since this is only something that we're coming to realize now. So, for instance, if we look at males and females, the first thing that is clear, certainly to me in a non-scientific way, is that males and females are completely different. Bodies are different. Yeah, females tend to be shorter. Certainly in my case, I'm definitely short and perhaps more overweight than where I should be. And all these things will impact, how drugs are working in the body. So for instance, when we give drugs, they go through the liver to be metabolized. Women tend to have smaller livers than men. They tend to have longer gut time transit, meaning that when we take a tablet, it takes longer for us to get rid of this tablet. Also, we tend to have higher pH in the stomach, meaning that we're more likely to develop gastritis or duodenitis or irritation of the stomach in general. And you probably recognize this. A lot of you will be thinking, yeah, every time I take tablets, I need to take something to protect my stomach. And of course, in a considerable amount of cases, particularly in the context of psoriatic arthritis, women tend to have a higher body fat index. And this matters because even if we're not clinically overweight or obese, yes, being overweight, particularly when there is extra fatty tissue around the waist, matters. It's not the same being overweight when you are a big person with big bones and a lot of muscle. It matters much more if the weight is around your waist, because that means that that particular fatty deposition will actually contribute to inflammation by itself. And this is why a lot of women, when they come to clinic, we say, oh, your inflammatory markers are not completely there. They seem to be a little bit high. And a lot of the time, this may not be necessarily coming from the joints. It may just be coming from the extra weight. And another thing that we're just only starting to understand is that at the immune system level, which is where our drugs work, drugs that we give in rheumatology and in the context of axial spondyloarthritis treatment, immune systems are very different between males and females. So for instance, when we see people getting sick very rapidly with a really bad infection that is going to need sometimes care in the ITU, it's not very common that we see that. But if we do, we tend to see this more often in males and females. So males can produce these very severe inflammatory responses. And in general, when we do bloods in them, we tend to find more abnormalities in the blood test than the one we do find on the females. Whereas females have got a different behavior. So they tend to be more on the autoimmune streak. So it's more common that females are going to have concomitant celiac disease, thyroid problems, perhaps, skin psoriasis, and other conditions. So it seems that inflammation in females tends to be associated to other areas of the immune system being active. And in particular, we know that female hormones matter because some diseases, such as rheumatoid arthritis, for instance, tend to go in remission when people get pregnant. Yet they don't in the context of axial SpA, when some females tend to have more disease activity and more back pain problems when they are pregnant. So there are things that are not behaving the same between the sexes, and they need more investigation. But one of the things that is very frustrating for us is that if you think about the clinical trials, which are the trials we do to test drugs, in the majority of the cases, we are not adjusting these trials according to sex. And a lot of you will be thinking about this now. Oh, I remember when I was offered to take part into this particular study, but I couldn't do it because they were asking me to not get pregnant. They were asking me to have very strong contraception. And what happens is we are biasing the studies because we don't let young females take part, because they need to be absolutely clear-cut and non-like about not having sex when they are on the study, unless they can definitely confirm that they're not going to get pregnant, which is just not realistic, is it? I mean, it's just not pragmatic. And this is a huge problem because we can test drugs in young males and we know perfectly well who's going to respond to what sometimes, when we don't know perfectly well, but we can definitely work out, we have better parameters to judge how drugs are going to to help males than what we have in females. And beyond that, I mean, if you think about how drugs are developed, they are first tested in animals, and these animals tend to be male. Can you believe it's male mice rather than females? And the same with volunteers. The majority of the study of the patients that take part on phase 1 trials are actually males. So there is a lot that we need to learn here about how we develop drugs. And another thing that I wanted to tell you before I finish is one thing that also we have not had into consideration. Now, you look at this graph and you think, well, I mean, how can people not realize that a woman's journey is completely different from a male journey? The moment that we go through puberty and we get on our teenage, we start menstruating. And that dictates an awful lot of what our life is going to go from that moment onwards. And I was just talking to Zoe now as to how much we ignore sometimes, you know, people's and women's problems, for instance, with menstruation. There is a lot of, or a very high prevalence of fibroids, endometriosis, and other problems that are actually making females' life misery. And not only that, but, you know, they can actually contribute to back pain. And these things are not taken into consideration necessarily when we are diagnosing axial spondyloarthritis. But also, if we need to treat, then we need to think about females wanting to be sexually active, which means that some drugs won't be recommended, and they won't be something that we can prescribe. And of course, this will also be in the context of pregnancy or breastfeeding, when a lot of the treatments are not recommended. But another area that I think is terribly, terribly misunderstood and completely under-researched is the menopause. I mean, how can people completely ignore the menopause? I mean, any of you that has been through that means that you've been through your menarche, through your puberty, through your sexually active years, perhaps through pregnancies, deliveries, whatnot, and then you arrive at the menopause. And when is the misery going to end? Yeah, hormones plummet it down, and then you end up with all the problems. Wear and tear tends to kick off at the time of menopause. Back pain tends to kick off at the time of menopause. So any protective benefits that we may have had from estrogens then disappear when the estrogens go. And not every woman can take HRT because of the risks that come with HRT. And again, all these symptoms will be affecting back pain, and they're very likely also affecting the activity of the arthritis. So as you can see, the agenda of research or the agenda of the unknowns is absolutely massive. But the take-home message that I always get from this type of information is that we really need to not only improve research, but also improve communication. And I think it's extremely important, and I want to believe that certainly we try to do this with our patients in our clinics, is we need to treat the people in front of us. I mean, it's very easy when we are in a very busy service to just go through 40 patients on a day. You know, you just wear your medical hat on, that you say, this condition needs to be treated, blah, 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 blah. But that's not the case. You know, textbooks tell us something, but patients in front of us tell us many other different things. And what is important for one person may not be important for others. And something that I always tell my juniors in clinic is you have to stop talking about patients when you come to clinic. It's not about having a patient in front of you. It's about having a person who's got a condition and has individual needs associated to that condition and to the person they are. So I hope I've been able to summarize and convey some of these extremely important messages. I think as women, we have drawn the short straw in many, many ways in life. Certainly in the context of Axial SpA, this remains very much a misunderstood, misdiagnosed condition. There is a huge delay in diagnosis. Women experience a high burden of disease with really low quality of life in some instances by the time they come to see us. And even if we can offer them a state-of-the-art drugs, not everybody will have the same response to them. So lower treatment response, shorter time of treatment is something that we see time and time again in women when we compare them to the male counterparts. And of course, a woman's journey is not linear. And as I'm sure all of you are there who are female with Axial SpA know and understand, you've got to verbalize this. And any other problems associated that you think may be impacting on your axial SpA symptoms is something that we very much, your doctors, would like to know when at the time that you come to see us and discuss your problems. So this is as much as I wanted to say. I hope I haven't gone over time, sorry.
No, that was perfect. Thank you. Absolutely crammed full of really interesting information, and from the comments coming in, everyone's really appreciated it as well and found it really fascinating so far. Yeah, so thank you so much, and also really, really nice messaging, and I think it's really good just to get this conversation going and get it out there more about sort of the needs of females with axial SpA. We've had a few questions coming in. If you're happy to answer a few questions, that would be really great.
Absolutely.
Lovely, thank you. So the first question we have is from Serena, who asked, given that females and males tend to have different experiences of axial SpA, do the current guidelines for treatment, such as NICE guidelines, differ in their recommendations?
No, it's shameful to say, but not a single guidance, not only the UK-based ones or the European or the American ones, not a single guideline differs. And part of the reason is because when we issue guidelines, they're always based on the available literature. So as scientists, we need to be extremely orderly in our methodology. So we cannot just say things because we think they are relevant. We need to look at what the research tells us. So we need to have objective hard evidence. This evidence will be coming. We are now more and more aware that we need to do the stratified trials in which we say, okay, we need to have so many females on this study. We want to treat so many females with this treatment versus so many males. And then we will be able to formulate these recommendations. But everything that we do in the medical context, absolutely everything has to be completely rigorously followed and developed.
Mm. So it is hopeful that hopefully more of those changes are going to come through with the
absolutely
research. Yeah,
we are in a much better place. Yeah.
Oh, good. And kind of along the same lines, Jeff asked before the session, again, because of the differences between men and women, would you recommend that men and women have different ways to self-manage their axial SpA, or is the advice quite similar?
So that's an excellent question, Jeff. Thank you. I mean, I think self-management is absolutely essential. And the reason why I think that is because you are the expert of your symptoms and your body, okay? And as doctors, we are sometimes quite pigeonholed, we think in silos because we have to have so many things on our head when we see you. So even if we are so-called experts in one condition, when we treat axial SpA, we're treating multimorbidity, lots of conditions. So I'm seeing you in clinic and I'm asking you questions, but I'm thinking, could it be osteoporosis? Could it be heart disease? Could it be chest disease? Could it be something else? Yeah. And all these things means that sometimes we go off track. So you know what is important to you, and that is going to help your self-management. So for instance, flares of disease, we do not have guidance for flares because every person's flare is different, okay? And within this, of course, sex will have importance. So for instance, I have female patients who will always have worse symptoms at the time of their periods. Mm-hmm. And this is worse back pain. But I also do have patients that have worse back pain at the time of the ovulation, which is not the time of the period, it's in between the period, mm-hmm. okay? And it's just this sort of thing that people will understand about when to take the extra anti-inflammatory, for instance, when to go for the extra stretching exercise, okay? So again, we don't have a guidance that fits all, but we're more and more trying to get people to understand that when you go to the NASS sessions, for instance, to do your stretching exercises, you very readily are going to learn which stretching exercises work for you. And one of the problems we have for exercise is that we cannot prescribe it. And if you go to different doctors, they will come up with different ideas. So I always think that stretching is good because stretching will reinforce the back muscles. And the stronger the back muscles, the more they offload from the bones. And when you have inflammation with the arthritis, it goes on the inside of the bone, okay? So, but everybody will understand this differently. So this is why we need to work together. But your question about self-management, at the moment, there are no guidelines for self-management that differ between females and males, yeah? but there is greater understanding that each individual's disease is different. And that's when self-management comes into place.
That's really helpful. And I suppose, would you then recommend to women to track their menstrual cycle and their axial SpA symptoms alongside each other to try and look out for patterns?
Yeah, for instance, I mean, menstrual cycle can impact sleep. And sleep is one of the things that can impact your stiffness and your fatigue in the morning. Yeah, so this sort of thing is important. For instance, going back to Jeff's questions, one of the things that I always find interesting is that swimming is something that gets talked about a lot in Axial SpA. Okay, but of course, swimming is very good when people don't have any structural problem on the spine. If somebody has a fused neck or a fused lower back, you're gonna find nearly impossible, yeah, to do breaststroke because you cannot keep the head above the water. Likewise, if people have the shoulder problems, they're not going to be able to do crawl well. So again, you know, this is when you have to adjust, yeah, and self-manage and say, well, perhaps for me, what works is walking on the water. I tell people, just get on the water because just by virtue of the warmth of it is going to help you. And then you can sort of perhaps just walk, move the water around, and with that, you're already doing the right movements. So all that matters, yeah. But yes, in the context of females, who may have exactly, you know, problems around the menstrual period, postpartum, during pregnancy, you know, for instance, we don't have any antenatal follow-up for these patients. I think that is outrageous. I think every single pregnant lady wanting to get pregnant should have a dedicated team that includes a midwife and a physiotherapist that are going to talk to them about bespoke exercises for them. Some people are very tall with really long trunks. Other people are very short with really protruding lower backs. So some people, when they are pregnant, they carry the baby inside and they get told that they're very neat. Others, like myself, are like transatlantic vessels, you know, carrying the whole weight of the body in front of you. But that's because we are shorter. And all these things are not necessarily talked about in the clinic, but they're extremely important because they can cause flares.
Absolutely. So that kind of getting the team around you to all communicate with each other is really helpful. Definitely something we can work on.
Definitely.
Yeah. Kind of linking into that topic a little bit, actually, Fern asked during the session, she said that she finds it hard sometimes to differentiate between sort of abdominal pelvic pain, whether that's her sacroiliac joint, whether it's maybe gut pain or period pain. Do you have any advice for that?
Yeah, no, that's a tricky one because the likelihood is that possibly all of those pains are contributing. Yeah, I mean, I think we see a lot of women that have a lot of symptoms and we don't find anything ever on the scans or on the SIJs. Yeah, they may be B27 positive, they may have other symptoms. Sometimes it's really difficult to say. I think overall, if we don't find anything on the imaging, it means that the disease is not as bad. I know it's easy for me to say, and a lot of you would be thinking, yeah, but it hurts. Yes, but perhaps we need to try and work out what hurts. Okay, and I understand what this person is saying, that sometimes it's very difficult to do. But if you're already taking a biologic treatment, for instance, for your back arthritis, and you're still having symptoms, just try to elucidate what causes the symptoms. Sometimes it's abdominal inflammation, because people with this condition, 30% will have some degree of abdominal inflammation that may not show up on an endoscopy or in a colonoscopy. Have a look at what foods, for instance, may trigger that off. See whether you go to the toilet more often. Yeah, see whether you can work trying to reduce some things that you may find are more, you know, give you more symptoms. And again, with the period pain is something that you can work around easier because you can always take an anti-inflammatory and see whether that goes. And just do a chart and see when does the pain come along. And does the pain go? Usually pain that comes with arthritis will be worse in the morning. It will get better across, you know, as the day goes along. If the pain happens anytime and it gets better when you lay down, that's unlikely to be the arthritis being active. It's more likely to be a mechanical problem or coming from elsewhere.
Oh, that's really helpful. Thank you, Fern. I hope that will help you sort of work out the pattern of your pain and see if you can differentiate between that.
And discuss them with the doctors when you go in, yeah?
Absolutely, yeah. And we've got lots of comments from people sharing that they have very painful periods. So would you recommend they ask their GP to refer them to gynecology?
I mean, you know what? Why should you be suffering? I get really annoyed with this. Yeah, I mean, I know people whose life just moves around period pain. You will You will organize your family gatherings, your night out, your holidays, your sex life. Come on, give me a break. How many males do that? None. Okay. So first of all, you've got a problem. You try to get it sorted. So I think if you have a lot of pain that is bending you over and is stopping you from going to work, you definitely need to have that looked at. And if the pain comes with a lot of bleeding that lasts far longer than 3 days, come on, you need to have that sorted. And it may be that you just got a fibroid and that something very quickly, can be done about it. It can be burned. But it may be that you've got endometriosis, and that's more complicated because you're going to need to have follow-up and you may even need to have treatment. So I would definitely encourage that. And I know that a lot of you would be thinking, yeah, try to go past my GP. Yes, try to go past your GP. You go back and you say, I cannot go to work. I cannot do my day activities. Just make it sound like what it is and see whether something can be done about it. If it is just the odd aches and pains, and again, you can take an anti-inflammatory or paracetamol and it goes, it may not be too bad. But if the pain is bending you over, you need to do something about it, particularly if your bleeding is abnormal or if your bleeding is erratic.
Absolutely. Yeah, definitely. Just keep pushing for that referral, definitely. God, we've got a lot of questions coming in. I'm sorry if we run out of time, everyone. We can, if you're happy, Helena, I can always email you any questions we miss if you're happy for me to do that. Just trying to keep on topic as well. So Johan asks, as women, we would also like to know how this impacts our children as well. I suppose that's quite a broad question.
So that's a very good, that's a very broad question. Do you mean children who are affected by the condition, or do you mean the chance of your children being affected? And if that is the question, which I guess it probably will be, because if your child has got the disease, they will be followed by the pediatric team. And when disease starts in childhood, it may very likely go through a period of remission when they go into the teenage and they won't have as bad symptoms as perhaps you. But if the question is, how can this go to my family? There is no clear answer, because this disease doesn't depend on one gene, it depends on many genes. The transmission is not what we call Mendelian transmission. Mendelian transmission means that if the mother has it or the father has it, the children will have a 50% or 100% chance of having it. It doesn't work like that. If you as a female have it, the chances of your children having it are less than a third. If the male, if the father has it, is far less than that. So there is a stronger chance with a female, but it's not higher than 30%, it's far lower than that. So I think it's not something that you need to think, I'm going to test my children, because there is no test that you can do. And even if you say, let's test my children and say that they are B27 positive, that doesn't mean they're going to develop the disease at all. So we're doing a lot of studies now trying to elucidate this and trying to come up with scores that may predict this better. But at this moment in time, no. I think your children will have a higher chance of developing it than the next door neighbor that may not have AS, but that doesn't mean that they're going to develop it 100%. It just means that you need to be more aware. Yeah. That's
really reassuring. I think we might have time for another one, maybe two questions. So one of the questions we had beforehand was from Catherine, who asks, how does axial SpA change during the perimenopause and the menopause?
Very good. Okay. So quick answer, we don't know. But I suspect, because I have a lot of women in my service, that it gets better with time. Okay, so I think it definitely tends to be worse in the when it presents early, around the 40s and 50s. Okay, and I think what you tend to get beyond 60 is more the degenerative change associated to the past inflammation, so achy hands perhaps, but it's very rare we're going to have a lot of inflammation beyond 60s. One word of caution though is that we do have a subset of women who will present after the menopause. They're not very common. They're going to be probably less than 20%. We call it late onset AxSpA. It tends to be similar to PMR, to polymyalgia presentation. So it's women who tend to be B27 negative, and they will come to clinic with a sudden onset of a lot of pain, particularly in shoulders, hips, a very high inflammatory response, and very fatigued. And when we do the scans, we find a lot of inflammation, very high inflammatory response. But we actually make the diagnosis and people do very well on treatment. So in general, if your arthritis starts in the early age, it will slow down and it will die off slowly. If it starts at the time of the menopause, it goes on a peak, but then it comes down again. So the good news is that after years of suffering, as we grow older, things get better. And I want to believe that with the impact we are making now, treating early, we are seeing less and less problems with deformities. I know that some of you out there listening to us are not in this group. I know that some of you have had the disease for very long and started well before the era in which we had strong biologic therapies. But hopefully, I want to believe that this is now changed.
Fingers crossed. And actually slightly linked to that question, do the changes that we get in joints with axial SpA, do they progress into osteoarthritis at all?
Yes,
or do they remain?
yes, yeah. And that tends to be particularly on the peripheral joints. So rheumatoid arthritis, gout, psoriatic arthritis, they're all the same. So just think that once you've had inflammation in the joint, that is a poorly joint, okay? So it's easy for problems to home there. It's easy for that to be the weak joint, the joint that is going to end up perhaps needing a replacement, the joint that if you knock is going to give you more problems. So it's once the arthritis has been there and the inflammation has been there, that becomes weaker.
Okay. I'm going to make this our final question because I'm aware of time and you're in clinic at the moment. So Rebecca asked, this is a research question. So Rebecca asked if you could have a qualitative research project from a sociologist, what about diagnostic delay? What research question would you be interested in investigating?
Oh, fantastic. I would say that Rebecca is actually looking at an epidemiology study. Please come and talk to us and to NASS, because that's exactly what we need to do. I mean, I think what we need to do is we need to put money into this condition. We need to translate every single step of the journey into how much money that is costing, not only to the individual, but to the society, because that is going to make the government listen. If you say that having a diagnostic delay, is costing the government hundreds of thousands of pounds per patient over a lifetime, they're going to say, we've got a problem here, which is what's happening in other conditions. But other than that, there are many questions. But the difficulty that we have is that this is a disease that has no specific signs or symptoms. So we don't have a diagnostic blood test and we don't have an imaging test. So it is always going to be very difficult for us to shorten this diagnostic delay. And the most important thing that we can do is raise awareness. So the moment that people start with back pain, they think that it can be an arthritis. I think that is what's going to be making the bigger impact. Yeah, absolutely. And if we can work towards that, Rebecca, we definitely will love working with you on this.
Brilliant. I'm happy to pass your email address on if you're happy for me to. I'm going to have to call it a day there. I don't know how much I can say. But absolutely at NASS we're doing everything we can to work on that diagnostic delay as well. So yeah, keep an eye out for all our Act on Axial SpA posts on how you can get involved in that as well. So we'll finish up there. But as I said, I'll make sure I go through and check all the comments, and any questions we haven't covered, I'll pass through to Helena if you don't mind. Thank you so much. That has been a fascinating session. I know we could probably be here for another few hours, but I appreciate your time so much.
No, but thank you for inviting me, and thank you to all of you there for spending this time with us. And as Zoe says, I think we are very lucky in this country to have NASS. They are the perfect advocate for this condition, and things are moving really, really fast now. I know it may not feel like it to you guys, but we have moved on an awful lot. And I think the best thing that you can do is, work with NASS. Even if you don't join the society, just keep talking to them and giving them your impressions and raising the areas that you think need to be researched.
Thank you so much. And yeah, thank you everyone for joining us live, and lots of lovely comments coming in as well. So really well received. Just finally, I'll share with everyone our next session is going to be in a couple of weeks. That's on Wednesday, the 8th of December, and we're joined by Ian Young, who's going to be doing a somatic movement session focusing on the spine. And finally, I've popped a link in the video description to a very quick survey. So if you have a couple of minutes, please do fill in the survey and let us know about any other topics you'd like us to cover in these sessions, and give us your feedback. Really appreciate it. So thanks again, everyone, and thank you, Helena.
Thank you.
And
Bye for now.
take care.